Good evening to everyone that's joining us, and welcome to this webinar co-hosted by the Bapm team and Bics. We will be starting shortly, but just to draw your attention to the instructions on the original slide. So your speakers and cameras will be muted, but please do put questions in the chat. And if you want to raise your hand during the Q&A session at the end, please do, or just type your questions in the chat. Thank you. Louise, was there any other housekeeping that you wanted to share, or else that I'll start us off?
No, all good, thank you.
Thanks, Louise. So forgive the slight binging that may continue as more people join. I am Sarah Bates, and I'm the quality lead for the British Association of Perinatal Medicine. I'm really honoured to be here today with Louise and the team from Bics. I'm just going to open up my slides with you. Okay. So today's webinar is really all about optimisation for preterm babies and women at risk of preterm birth. I'm going to open the webinar setting the scene for why this is needed, to talk about a optimisation pathway. And then we have a number of other fantastic speakers following on, including Professor Andy Shannon to talk to us about targeting steroids antenatally. We have Julie Claire Becker, who will be talking about an upcoming Bapm resource for optimising perinatal team culture, and a number of other brilliant speakers. So, as I said, I'm the National Quality Lead for Bapm, and in my day job, I'm a neonatal consultant at the Great Western in Swindon. I've been interested in preterm perinatal optimisation for a number of years now, having started a small project in my own unit and having been the operational clinical lead for Preterm across the southwest of England, which is a preterm perinatal optimisation pathway project. And in October of last year, I took over from Julie Claire as the National Quality Lead for Bapm, and have been really focused on implementation of preterm optimisation and supporting teams across the country with their own work streams on this topic. So Louise has really asked me to cover, why do we need a preterm perinatal optimisation pathway? When I show you the pathway, I'm sure you'll agree that much of it is not new, and many of the metrics on there will have been performing well at in our respective units. But I think we really do need to look at this as a pathway, and we need to look at this as a pathway that's delivered by a perinatal team. I think for too long, there's been neonatologists working on certain elements, obstetricians working on other elements, midwives driving forward care, neonatal nurses, but it's not until we come together as a team that we can really see change, particularly in some of the metrics, such as optimal cord management or delayed cord clamping, which you'll hear more from Tracy about later on. So if we start with the global picture, why do we need a preterm perinatal optimisation pathway? And ultimately, it's because if we look at health outcomes globally, being born early is the leading cause of cerebral palsy and the leading cause of death amongst children. And it's thought that globally we really could prevent many of those deaths with current cost-effective interventions. And when I first saw these WHO statistics, I was very guilty of thinking maybe that's just in resource poor settings. Maybe that's not the case in the UK. Maybe actually many of these deaths and brain injuries are not preventable. But I don't think that that's the case. So this is where we're at in the UK. And we've got one of the highest infant mortality rates in Western Europe. And you can see many of our nearby countries there significantly better rates of infant mortality than we have. And that was back in 2018. And So what's been the trend across the United Kingdom? So this is Embrace data from 2013 to 2019, and you can see that overall in the UK, the extended perinatal mortality rate has been falling, but that's predominantly due to a reduction in the stillbirth rate. And that's most marked in England, but it's certainly not necessarily totally matched in the other nations of the UK. And we're definitely not seeing the same fall in the neonatal mortality rate consistently across the UK. If we look at 2020 data from the National Child Mortality Database, we can see that an overwhelming proportion of these infant deaths are related to prematurity. That's 1 in 3 deaths under 1 year was born extremely preterm, but over 2/3 of all infant deaths are in babies who were born early. So it's really clear that if we want to tackle this problem that we have in the UK with our infant mortality, we really need to be focusing on prematurity. The National Neonatal Audit Programme in 2020 comments on substantial improvements in some of the perinatal strategies, but there's huge variation between neonatal units and networks. I know that Tracy will comment on the substantial variation that exists in the implementation of optimal cord management or deferred cord clamping later on. But there's also this huge variation in mortality within our own country across the regions in England and Wales that contribute to NNAP. And this shows that data, the mortality for babies born under 32 weeks is hugely variable. And if you take the region with the lowest mortality and compare it to the region with the highest mortality, it's nearly double. And the same difference is true for those born even more prematurely. So the same discrepancy and variation exists for those babies born under 28 weeks gestation. So how about brain injury? We've already established that in terms of the mortality within the UK, we aren't performing well, we're not improving, and there's massive intra-national variation. So with brain injury, sadly, the same is true. If we look at the annual rates of brain injury for preterm babies from 2012 to 2019, and this is data from Chris Gale's group and Imperial in London, we're seeing very little change. So I'm sure you'll all be aware that a lot of what I've just shown you has led to the NHS long-term plan goal to reduce brain injury and death by pretty substantially ambitious targets. We didn't meet the 2020 target, and we are not on track to meet the 2025 target. So why is that? Because the evidence base is pretty robust for what we need to do to improve mortality and brain injury in preterm babies. But we're not doing it consistently enough for every single baby, every single time in every region of the UK, and every type of neonatal unit or every type of perinatal unit. So are we as good at some of the performance measures in the fetal medicine centres with the co-located NICU as we are in the District General Hospital maternity units with a co-located LNU? And I think there's a lost in translation gap between research and implementation. Antenatal steroids, which hopefully Andy will cover later, a huge gap between having the evidence base and translating it into clinical practice. And currently we're at a position in the UK where most women delivering prematurely will have had antenatal corticosteroids, but as I'm sure Andy will mention, the proportion receiving appropriately timed steroids is really low, and that's going to be a major target for us all. NNAP has changed its steroid criteria for 2022 to collect data on accurately timed steroids, so I think this will be a QI journey we'll all be on. This is a slide I made a very long time ago and continue to use. It still very much resonates with me. And it's around this responsibility that every single one of us on this webinar today has. We might be a neonatologist, a neonatal nurse, a midwife, an obstetrician, or any other perinatal professional. If we're involved in managing a woman and her baby around the time of preterm birth, we have a huge responsibility on our shoulders to take this baby from an in utero environment through delivery and stabilisation, and making sure that it has the vital evidence-based interventions that alter its chance at being able to grow, survive, walk, talk, and lead a good quality life in the future. So how do we do that? And many of you will notice that some of the terminology I use here is very similar to that used in Saving Babies' Lives Care Bundle. And that's because element 5 of Saving Babies' Lives Care Bundle obviously refers to preterm birth. And with the upcoming revision, version 3, element 5 will be expanded to include these key optimisation elements. But it's about prevention of preterm birth and risk assessment of these women, and then accurate prediction, which again, I'm sure Andy will cover very eloquently shortly. But it's about the optimisation care pathway as well. So this is Bapm's perinatal optimisation care pathway. And it consists of the antenatal optimisation elements, so place of birth, which I know Manju will cover shortly, antenatal steroids, magnesium, which largely we're performing reasonably well at across the UK thanks to the Precept programme. It's intrapartum antibiotics for women in preterm labour, optimal cord management, keeping the baby warm within an exact temperature range, and ensuring that baby can have early maternal breast milk within ideally 6 hours of birth. So Bapm has worked in partnership with NNAP to produce a series of optimisation QI toolkits to support this pathway. Oh, sorry, let me just go back to that. To support implementation of this pathway. And I'm hoping that many of you may have seen some of these toolkits. If you haven't, and you're working on optimisation in your own unit, please do go and find them off the Bapm website. There's lots of helpful tips and QI methodology to really drive forward change. But you'll see that the elements of the perinatal optimisation pathway really rely on being delivered by a perinatal team. And you'll hear from Julie Claire later about how vital the perinatal team culture is at successful delivery of this, and also some really useful suggestions in how we can both measure and work to improve culture in our own units. But you'll also see it sits within a very strong quality context, and that relies on QI knowledge, QI skills, capability, and really there's a lot of overlap there with culture. And you'll see very much at the bottom, it's about working in partnership with parents throughout this perinatal pathway. So just very briefly, clearly within NHS England, optimisation is a key part of the maternity and neonatal safety improvement programme. It's one of their key drivers, with improvement of optimisation and stabilisation of the preterm infant for the patient safety collaboratives. So I just wanted to give you an example of how we've been delivering this in the southwest of England. Oh, sorry. So we have been working on a programme called Preterm, which is a care bundle of 11 elements. You'll see that the 7 elements are very common with the Bapm pathway and the MATNIA SIT programme, so it's what we've used to deliver those targets within the southwest. We've got 4 additional neonatal elements as well. We launched that in January 2020, so just over 2.5 years ago, and delivered it into all 12 perinatal units in the southwest in partnership with both of our local academic health sciences networks and our operational delivery network for neonatal critical care. It very much built on Precept methodology, and indeed my co-lead for Precept for Preterm is the National Precept Programme lead, Professor Karen Lloyd. So forgive me for a busy slide, but essentially just to share with you some headline outcomes from implementing Preterm in the Southwest, really to show how absolutely feasible this is to implement as a pathway, and also to show some of the change that can be delivered by working on perinatal team culture, QI capability, coaching and in-unit support and backfill funding for nurses and midwives in the units. So you can see we were able to generate change in almost all of the elements of the pathway, but very specifically we're able to generate a really significant improvement in the percentage of interventions received by all mothers and babies in our region. But it wasn't just the numbers that changed. We really saw that working on this perinatal optimization pathway resulted in improvements in qualitative measures, including team function, situation monitoring, communication, and other key elements of a strong perinatal team culture. And I think that working on Preterm in the Southwest has had benefits for lots of the teams outside of their preterm outcomes, lots of the other areas of perinatal care and perinatal safety have benefited from the improvements in team working. So I've included a couple of links down the bottom if you'd like to read more about Preterm. Preterm has worked with Bapm and Bics to produce a perinatal optimization pathway passport. We haven't quite released this yet, but just a heads up that this will be coming. This was one of the most useful documents to support implementation of optimization in the Southwest, and it's been one of the resources that people have most asked for. All the Preterm resources are free to download, but for just the 7-element pathway, this is the adapted passport. And the idea of this is that this is kept on all the delivery suites, and it's started by quite often the midwife or the obstetrician admitting a woman at risk of preterm birth at less than 34 weeks gestation. And you can see that it acts like a prompt and a useful source of data collection to track the implementation of the optimization pathway. It will come with an equivalent passport that is designed to be parent held, and really to start informing and engaging women or non-birthing partners as really a key part of the perinatal team. So just to bring this together about what we've learned from working on perinatal optimization in the Southwest, how might that inform teams around the rest of the country who are also working on their own work streams for optimization? I think the whole point of today's webinar is about galvanising the support of the whole perinatal team. In each of these centres across the Southwest, we had a quad team of the core Preterm team was formed of an obstetrician and neonatologist, a neonatal nurse and a midwife. And I'd liken that to a 4-wheeled car. It's absolutely key to perform really well. Sometimes we didn't have all 4 members of the team at any one point or in any one meeting, and it can work just about okay with 3 wheels. We've all seen Robin Reliance driving around. But if you start to lose 2 of the wheels, especially if they're on the same side, so if, for example, we didn't have great leadership from an obstetrician and a midwife in that centre, then the car falls over. It needs the support of the whole perinatal team. And so to be here today on a meeting with lots of obstetricians and midwives and neonatologists is brilliant. Using the power of the evidence base is super vital. Tracy will definitely touch on this later, I'm sure, with optimal cord management. That's a great example where sometimes people don't know the impact of immediate cord clamping, the substantial increase in mortality that might result from a practice of immediate cord clamping. There's definitely something about recognising the time and the resource and supporting teams to be able to deliver the quality improvement in this area. It is really time consuming and takes a lot of focus to create change. We definitely saw the benefit of celebrating success, and that really highlights the need to use your data well to initially show where you need to work, but also on really celebrating when things have gone well. And that really helps to engage the team to embed and sustain the change such that the perinatal optimization pathway changes from being something new, something that you're working on, into being just the way things that are done when we have a woman at risk of preterm birth. So just finally, I felt it'd be slightly remiss of me to talk today without mentioning the momentous events that have just that we've just been through as a nation. And whatever you may or may not feel about the monarchy, there's no doubt that she was a pretty amazing lady, and this was one of the most fantastic quotes that I remember very vividly hearing from her. And I think this is very applicable to implementing preterm perinatal optimization. It's about finding ways of encouraging people to combine their efforts, their talents, their insights, and crucially their enthusiasm and inspiration to work together. So thank you so much, and I will hand over to Andy. I'll just unshare my screen.
Great, Sarah, thank you so much. I'm just going to share mine and just make sure I can do that. I hope, can you see that all right?
Yes, that's great, Andy. Thank you.
Fantastic. All right, so I've got 10 minutes to tell you about something which I could talk for hours about. But I will give it a go because I think the audience here is really key and important for implementing what I think should be a change in practice. Just quickly, that I have declarations to declare, but only very few related to commercial work and none that give me personal financial gain, which I think is important when you talk about products related to prediction. I want to start with two anecdotes, really. Two patients who I actually met a couple of weeks ago. This is Noah, who had steroids and mag sulfate in a timely manner in 2010, and I met a mother recently. Her daughter Noah is doing phenomenally well, is above centiles in growth and intelligence, and doing incredibly well at school. So it's a good news story that people can do well. And I also met this patient 2 weeks ago, Katie, whose child came into us with failing stitch, multiple previous mid-trimester losses. And actually we admitted her for some weeks, even months, and still Max here on the right went full term to 39 weeks. And I think this is a problem for us obstetricians. People do well, perhaps in spite of us a lot of the time, and we struggle to know what to do. And so Max actually got a lot of steroids, perhaps unnecessarily in retrospect, but we just didn't know at the time. So steroids we all know and love, and I don't need to say much to this audience about their importance, and the Cochrane collaboration logo actually represents the first 7 trials of antenatal steroids. And this is an old meta-analysis from Justice Hoffmeyer from the WHO from more than 10 years ago, but it's pretty consistent in modern meta-analysis, showing consistent benefit across morbidities. And when you repeat the doses, there is this slight insult of increase in fetal growth, worsening in fetal growth. So I'll just hit you with one of many guidelines. I happen to be involved with this one with FIGO. What do we now say? You should give steroids between 24 and 34 weeks in singletons or multiple pregnancies. I think what is changing slightly across all the guidelines is we're starting to ascertain that ideally it should be offered in a tighter time frame, in this case 18 to 72 hours, so more specificity here. But of course, if you are less than 18 hours, we do say you can still give them because they are likely to be beneficial. The problem is very simple, which is people coming in and threaten preterm labour frequently do not deliver in the next 7 days. In these studies, both from 97 and more recently in 17, showed that only 3% of babies are delivering in 7 days, which means if they're all treated, 97% are getting treatments that are in effect not necessary. And even in the Netherlands, where they're very good at targeting the diagnosis of preterm birth, it's still over 90%. And we are increasingly worried about the insult of antenatal steroids. In this case, a small study of 22 babies, half who did get steroids, half didn't, who went on to die, and the pathologist notes quite a profound effect on neuronal growth in the baby, and this is reflected in increasing numbers of clinical trials where outcomes in babies are associated with reduced neurodevelopmental abilities. For example, in this case, in the Preterm steroid trial, where babies receiving steroids were worse off as judged by their teachers in later life. And there are now numerous papers kind of showing this neurodevelopmental insult. So I just want to reflect on it from the obstetric point of view, because our neonatal colleagues will always go, well, why didn't you give the steroids if they weren't given? But what we have to think is the numbers needed to screen times the numbers needed to treat. Roughly speaking, you need to treat about 20 babies who actually deliver to reduce one case of RDS. You then have to multiply it by at least 10, because that's the number of babies who don't deliver, to get the numbers needed to treat. And in earlier gestations, that's in the region of about 200. And in later gestations, that's in the region of about 2,000. So if there is a harmful effect, it has to be 2,000 times better or kind of worse than the beneficial effect for reducing one case of RDS. And I think we sometimes get this balance wrong in our enthusiasm to treat patients. And so the European Association of Perinatal Medicine now actually makes a categorical statement for later gestational preterm steroids that it should be restricted to trials. And American organizations are sort of going this way as well, even though they were very enthusiastic about giving late preterm steroids. I got interested in this back in 2015, where the meta-analysis at the time, if I get rid of the significant, the non-significant features, are left with steroids only being beneficial for death and hemorrhage if they're given in less than 48 hours. And it's only RDS that benefits if it's given within 7 days. And importantly, given more than 7 days in advance, there was no sign of benefit, but only smaller babies. And again, there are numerous studies now demonstrating that given in a day or two is far better than being given later than that. And certainly beyond 7 days, the benefit deteriorates quite rapidly. I want to show you this in giving antenatal steroids to women with preeclampsia. In preeclampsia, we know when they're going to deliver because we make the decision. It's an indicated preterm birth. And even in this situation, less than a third of the babies are getting steroids within 7 days of delivery, which I think is pretty bad practice, because there's absolutely no reason why you shouldn't get it right. So we can't even get it right in indicated preterm birth. When you look at threatened preterm birth, more than 50% of babies are not getting a therapeutic dose of antenatal steroids. And so the various guidelines, in this case the clinical network, have actually stipulated you should avoid, if possible, 7 days or more, and they should be given optimally within 48 hours. And NHS England has followed suit and saying that the real metric is giving a first course within 7 days, which actually happens only in a very small proportion of babies. So the bottom line is most babies who benefit from steroids currently do not receive a therapeutic dose, and treatment only harms. So one solution is to use predictive tests. There are a number of them around. Cervical length and fetal fibronectin are perhaps the two most established. In order to kind of get these used in a sensible way, we've incorporated them into the QUIP app that allows you to instigate not only the tests, but also the significant parts of features of the history that contribute to the prediction. I think it's always important to say, don't forget clinical acumen. You should only really use tests when you know they're going to add value, and also they become far more cost effective if you direct them accordingly to cases that you think are going to benefit. And the Perilink system now, quantifiable fibronectin, can be used quite easily as a point of care. in this study, not from us, but it just demonstrates how they are synergistic. If you have a short cervix and a high fibronectin, nearly 100% of those people are delivering in 7 days, whereas conversely, they're both normal. Nobody's delivering in 7 days. And you can see from this graph that fibronectin is actually better than cervical length. So in other words, if you have a high fibronectin and a normal cervical length, you're still getting quite a few people delivering in 7 days. And there's other studies that have supported this. So the QUIP app basically allows you to put in these variables, the fibronectin status, the cervical length. If you don't have them, you don't need to put them in. It'll still work. You can put in whether they're twins. There's an asymptomatic version, and it basically gives you a risk of what you will do in the next 1 to 4 weeks, or before 30, 34 and 37. And you can show a little infographic to the woman to give her an idea about what her risk is if she's struggling. And when we've looked at the policy of using the app, and people like the 5% risk, we actually end up appropriately sending home a lot of people, and importantly, very infrequently sending home anybody inappropriately compared to what NICE currently recommends, which is to treat everybody. The Delphi consensus suggests 5% risk is good. Actually, most people have a risk of less than 1 in 1,000. In our big study here, when we used it over a number of units, like 13 units, the first thing to say is in pragmatic clinical practice, the prediction is excellent with ROC areas of 0.9, and only the 7 women who did deliver in 7 days all came back and were treated anyway, because their risk, wasn't necessarily 1 in 1,000, but they were still advised accordingly and safely. And those of you who like predictive statistics at a 5% threshold, this has a 99.3% negative predictive value, and 1 in 4 of these women were delivering in 7 days. So you can actually download it and use it as such. I'm going to finish with my top tips in the last slide. This is the controversial one because I know my neonatal colleagues just do not like this concept of withholding steroids unless we're really sure they're going to deliver soon. But if you do follow that policy, paradoxically, you end up giving far more babies a therapeutic dose. And the very rare case that you might deliver quickly is a very small price to pay for the many, many other babies that will get it correctly. I say use your clinical acumen, aim for 48 hours. Obviously repeat them if necessary. Caution, I think, in this late preterm area, and I think I've run out of time. Thank you very much.
Thanks so much, Andy. Over to you, Tracy.
Well, I feel slightly nervous following Professor Andy Shannon, but I will do my best. And somebody just confirmed that you can see my first slide.
Yeah, that's great, Tracy. Thank you.
Brilliant. So thank you for giving me the opportunity to share something that I'm really passionate about, which is optimal cord management, and a briefly 2 seconds on maternal breast milk, because I am also going to run out of time. So many of you may use the term delayed cord clamping or deferred cord clamping. And for the purpose of this presentation, I'm going to use optimal cord management because I think the term is better. When you say delayed, I think sometimes women and families feel that we're waiting to do something, or we're doing something when we're not doing something when we should be doing something. So I am one of the clinicians that work in the Southwest and have been privileged to be part of the Preterm team. And prior to the Preterm project, in our unit, we were not performing optimal cord management in our preterm infants. We were in our term population, but not in those that were preterm. And I was particularly blown away to hear that just waiting 60 seconds to clamp the cord of a preterm baby would decrease its mortality by nearly 1/3. That is massive. And I was very clear in our department that this is something that we needed to change. And to enable us to do that, we needed to do it as a team. We needed to do it with our neonates, our theatre staff, our ODPs and our anaesthetist. We needed to think about how we were going to stabilise that baby during the optimal cord management, how we were going to keep them warm, and whether we were going to offer them respiratory support. So this is the most recent NNAP data looking at optimal cord management, or they use the term deferred cord clamping. And as you can see, there is a variety, such a stretch of percentages across the whole of the UK, with most units clamping the cord after a minute in only 30% of cases. And at the end here, you can see the Southwest, which is currently at 60% and higher now, because of our Preterm project. And I hope to share with you some nuggets of information over the next few slides of how we in our unit have just managed to get 94% in the last year. I would encourage all obstetricians to know what their percentage is, and you may be able to, you can find that on the NNAP website. But the most simple place to find it is to look at your Badger data. So I have access to our Badger data. In fact, I add and addend the Badger data for our unit on both steroids, magnesium, IV antibiotics in labour and deferred cord clamping. So it may be that levels are higher than the 30% as shown in the NNAP data, and it's just not being documented in Badger, which is where they get their data from. So all obstetricians for the labour ward lead should be able to access and view their own data on Badger. So there's plenty of information out there to help you bring this into your unit, and Sarah's already mentioned the Bapm toolkits, which are fantastic. They have lots of information and updated evidence. They have driver diagrams and information on how you as a team can bring in optimal cord management in your unit. There's also information on the Preterm website, which you can find if you just Google Preterm. And if you access this, there is information and videos which are extremely helpful. So what are the contraindications for optimal cord management? Well, from a maternal point of view, if a lady is having a massive hemorrhage, you may wish to clamp the cord quickly. And for a baby, you would obviously clamp a cord if they have a bleeding vasa previa or if that cord is snapped whilst you're delivering. But often people feel anxious about clamping the cord in a set of monochorionic twins, and they shouldn't be routinely excluded for optimal cord management. You need to make an individualised care plan on an individualised basis. And I would say that you can optimally cord manage the second twin once you have clamped and delivered the first. There are units, not in the UK, that would say you can still manage a cord optimally when the placenta is completely abrupted by lifting the placenta above the baby and allowing at least a minute before you clamp the cord. When delayed cord clamping is not possible, the NALS or neonatal advanced life support do suggest that you should consider cord milking for those babies over 28 weeks. And I would say that most babies can have at least a minute of optimal cord management. We also get asked when we should give the uterotonics, and just a reminder that IM oxytocin takes 2 minutes and 30 seconds to actually reach the uterus. So waiting a minute to clamp the cord, there is no impact on the oxytocin or ergometrin that you've given IM. In respect to giving IV carbetocin, which we give at caesarean sections in our unit, it's still given very slowly over 2 minutes and therefore has no impact on the baby. So I would encourage you to give routinely if you're giving with the delivery of the anterior shoulder at vaginal birth or once the baby has delivered. You don't need to wait to clamp the cord until you give the uterotonics. Positioning of the baby is really important. Optimal cord management is not going to work if you've done a Simba and lifted the baby high up in the air and held it there for some time. So just a brief chat about the practicalities at caesarean section. As I've already mentioned, it's really important that we have a multidisciplinary team approach to how we plan and instigate this at caesarean section. So everyone needs to have buy-in to this process. And in our unit, we all got together, went into our theatre and worked out where we would put equipment, where people would stand, how we would ensure that our theatre trolley remained sterile, how we would ensure that we remained sterile at the time of the caesarean section. And I would encourage that it's really helpful to draw a picture, work it out, walk it through, sim it, do it, then replan it, rediscuss it, debrief it, and you might need to change. We also have a SOP that is laminated and on our resuscitaire, and we have a guideline on optimal cord management at caesarean section. How do we keep our babies warm? We know that our neonates and preterm infants get cold very quickly, so we need to ensure that our theatre is an optimal temperature. The neonatal advanced life support team advise that all babies should be born into a room at 24 degrees, and the most extreme preterm, the temperature should increase to 27. So for those perimenopausal women like me, it means we do sweat when we deliver these babies. When we started optimal cord management and delivering preterm infants at caesarean section, we used to put babies in plastic bags, and we used to use a sterile suction tubing bag. We've now moved on to the NeoHelp bag, which is obviously fit for purpose. But we also use additional equipment like a transwarmer and a sterile warm towel. In our units, our neonates scrub and give respiratory support while that baby is transitioning and while the cord remains intact. And we try and give at least 2 or 3 minutes of optimal cord management if we can, but you do not need to offer respiratory support. It's not mandatory. Some units may have resuscitaires like the one on the right that can be moved very close to the theatre table. In our unit, we use extra long PEEP circuit and a tray with a transwarmer on that's placed under a sterile sheet that works just as effectively. And as mentioned before, I know this is a term baby, but lifting a baby up and holding a baby in the air does not help the optimal cord management, and the baby will get very cold very quickly. As part of implementation of this in our unit, as I said, it requires teamwork, sharing of information, sims and debriefing and changing what we do. We've had lots of posters up. We always put a poster on the back of the toilet door because that's where women, our female population, often read information whilst having that 2-minute peace and quiet sitting on the toilet. And we've also put some information on our resuscitaires to remind staff. I would encourage you to all access the Preterm website because there's some great videos on there which are helpful to see this in action. Very quickly, just a couple of minutes on early breast milk. Again, just to reiterate that the baby receiving very early breast milk within the first 6 hours of life certainly reduces the risk of NEC or NEC by 2/3, and there's also really positive effects, other effects for the baby, and expressing very quickly after delivery will increase that mother's breast milk supply. Again, there's a Bapm toolkit on how we can optimise early breast milk that I would encourage you to have a read. Preterm have leaflets on their website, and there are leaflets available in multiple languages. And in our unit, we give them out to all women that are admitted in threatened preterm labour, ruptured membranes preterm, or have preeclampsia, particularly those on the antenatal ward that express whilst waiting before they properly brew and we need to deliver them. I'm sure many of your units have maternal expressing kits, but this is just a few examples. And just to reiterate that giving milk, we have the golden hour, and there are lots of things like golden drops when you access. And also, as obstetricians, I was unaware that even giving some colostrum onto a buccal colostrum onto a baby's lips is just as effective, even if the baby is intubated and can't receive breast milk through an NG tube immediately. This is just a slide to show how we've done in the Southwest in respect to babies receiving early breast milk. And as you can see, when we started this project in September 2020, we were at about 36%, and we've got up to about 76 and nearly 80%. There'll always be a population of babies that don't receive maternal breast milk. Not all women want to express, not all women want to breastfeed, and some women take medication where it is contraindicated. But certainly this is something new in our unit, and it's made a massive difference to those preterm infants. I hope I kept to time. Thank you.
Thank you so much, Tracy. A brilliant whistle-stop tour of both of those elements of the optimisation care pathway. And now we'll hand over to Julie Clare to talk about the real vital importance of perinatal teams and perinatal team culture to implement this. Thanks, Julie Clare. I can see your slides, Julie Clare, but I just wonder whether you might be having a problem with the sound, because I think you're still muted.
Ah, that's better. Hear me now.
That's perfect, thank you.
So thank you so much, Sarah and Laura and Louise, for asking me to come along today and speak about a brand new resource that the Bapm and the MAT-NeoSIP have been collaborating on to really underpin the work that has already been done on perinatal optimisation already. I am a consultant neonatologist from Edinburgh, and I have recently stepped down from quality lead with the Bapm. So you've heard already, we kind of done and dusted the perinatal optimisation care pathway in the last hour, and you'll know that the toolkits are all there for everybody to use. But Sarah has really highlighted the importance of the quality context and perinatal team culture in really underpinning the delivery of these toolkits and delivery of all of these evidence-based interventions as well. And I want to talk about that over the next 10 minutes or so. Importantly, there are an increasing number of national drivers for improving culture and context, particularly in maternity and neonatal services. And increasingly, this is around areas such as HIE and term birth, but also perinatal optimisation as well. And we've been delighted to see the NHS Safety Champions being put in place, and we're hopefully seeing a neonatal safety champion being established in the next year or so. But we've got a lot of other drivers, such as the NHS Patient Safety Strategy, the Scottish Patient Safety Programme in Scotland, NHS England Better Births, and the Maternity Transformation Programme. And I want to talk just briefly about the Kirkut report and the Ockenden report. So these investigations, the reports of these investigations are 7 years apart, with the Kirkut report back in 2015 and most recently the Ockenden report this year. And despite being 7 years apart, there are recommendations which are pretty much similar with both of these investigations, and that is that there's a real need to listen to patients and undertake shared decision making, that the standard of investigations should be better with clear implementation of action plans, that clinical leadership should be better, and particularly leadership in patient safety and quality, that multidisciplinary training across teams should be improved and across teams and sites and within networks, so that clinicians are upskilled in managing complexity, care pathways, risk assessment, and importantly, that there's an improved partnership between trusts and between trusts and networks. And if I was to take away the left and right hand side here, many of you would be thinking, actually, they're all things that we could be working at in our own unit as well. I can see gaps there. And I think it would be foolhardy to think that these recommendations are only specific for Morecambe Bay and Shrewsbury and Telford. Particularly as the Care Quality Commission report from published last year, Opening the Door to Change, looked at how the safe ratings had improved from 2017 in the pastel colours through to the brighter colours in 2020. And while there's been a modest improvement in the number of safe ratings for maternity units that are now classified as good, still around 40% of maternity units within England and is very extrapolatable to Scotland, Northern Ireland and Wales as well, I'm sure. The 40% are still either inadequate or requiring improvement. So there's definitely a lot of work that needs to happen, not just in maternity services, but across the whole perinatal service, because there are a lot of similar themes that we can find within neonatal services too. So what exactly is culture? And this is where everything gets a bit sort of intangible and a bit nebulous. So culture is defined as the beliefs, attitudes and assumptions of the members of the team that result in normalized and shared ways of thinking and working and practicing and behaving. And it becomes the way that people think around here and the way that things are done around here. But what about changing culture? So that in itself sort of is a lot more difficult to really kind of understand and get your head around. As I said, culture in itself seems to be something you can't really put your finger on, sort of in the ether. It can be really complex, so very sort of personality driven a lot of the time, and a lot of culture is very deeply ingrained. Culture is often led from the top, and those people at the top are usually the people who are the oldest, so there may be decades of attitudes and assumptions and beliefs and behaviours that take a lot to change. And culture exists on multiple different levels, not just within a hierarchy, but across professional groups. And anyone that's ever tried to change culture, either by improving communication or improving leadership, will know that the changes that you see are very slow to materialise, and it can be really hard to change as well. So there can be resistance and intransigence. And then you add to that culture around perinatal optimisation, and there's a whole added layer of complexity. And that's because there are multiple interrelated sub-teams. You've got the care of two patients to think about, often who are receiving prolonged episodes of care in complex care pathways, perhaps involving fetal maternal medicine or surgical pathways. And that might be the care might be taking place in different departmental locations and indeed different geographical locations such as primary care or district general hospitals or fetal maternal units. So it can be quite a daunting thought really about how we might go about changing our perinatal culture and improving it. I've talked as well about context and what is context. Well, it's very, it can be similar to culture. It is inextricably linked to culture, but really it means the readiness for change. And I want to illustrate that by talking about, well, just with an example. So, for example, we know that admission hypothermia is important in increasing the risk of mortality in the preterm infant. So Unit A decides they're going to deal with this, and they've got high rates of admission hypothermia. So they download the Bapm normothermia toolkit. They go through a process using all of the QI methodology that's suggested in that, and they reckon that they've got most of it nailed already, such as environmental temperature and so on, but they don't use plastic wraps. So they decide to use plastic wraps in all babies under 32 weeks, and lo and behold, they've an 80% reduction in hypothermia. Understandably, they think this is amazing, and they celebrate that by presenting their work at the Bapm annual conference, where there is a junior doctor from Unit B who thinks, crikey, that's great, don't need to do all that work. I'm going to bring in plastic wraps in my department. And what happens? There is no reduction in hypothermia. And the reason why there's two quite different results, it really just boils down to the context. So let's look at Unit A. So what Unit A is, they use the QI methodology that's suggested in the toolkit. They use tried and tested means to process, map what was going on with the preterm birth, draw driver diagrams, get team buy-in, multidisciplinary team involving anaesthetics, the theatre staff, midwives and so on, establish shared goals as a team, and they tested those goals and processes during sim training. And this is just what Tracy's just been talking about there with her optimal cord management. And they established pre-briefs before every preterm birth. And at the end of the month, they would feed back to staff on the successes or the difficulties that had been had, and so the cycle continued. Whereas in Unit B, this was a 3-month junior neonatal doctor project, which was led by a consultant with no QI training in a labour ward that was undergoing a refurb that was full of drafts and the equipment kept going missing. So you can see how context is actually vitally important when you're thinking about introducing or implementing the evidence, implementing a quality improvement project. You've got to get the context right, and you've also got to get the culture right. So you're saying, I can hear you screaming at me already, going, oh, you've asked us to get antenatal steroids right, you've asked us to do optimal cord management, now you're asking us to grapple with something as complex and challenging as context and culture. But what is the evidence? Well, apart from the huge amount of evidence that exists now in the adult literature, there's increasing amount of evidence around perinatal optimization. And this is just a handful of the literature that's out there at the moment. There's a lot more that is referenced in the Bapm toolkits that show that when you, as a service, invest in optimizing context and culture, either before or alongside perinatal optimization quality improvement, that you're much more likely to be effective than if you just institute a quality improvement project on its own. And that has been shown with place of birth, antenatal magnesium, optimal cord management, antenatal steroids, and preterm morbidities and mortality. So there is increasing amount of drive really and evidence to show that it's very worthwhile to put in that bit of effort to try and get that right first before we implement, or at least alongside any evidence that you're trying to implement, any intervention that you're trying to implement. So to help you out in that, we have collaborated at the Bapm with Matt Neosit on a resource which will underpin the quality toolkits. It's got a fantastic group that has been leading this, hugely enthusiastic and experienced, including parents and members of the wider perinatal team and organisational representation as well. And really the resource is split into 2 sections, and the first one is really helping you evaluate your context and culture locally, giving a range of different sources of data that can be collected and analysed, including staff surveys, parent surveys, trainee surveys, looking at your own performance in perinatal optimisation and the process mapping that might throw up problems with culture. It may come from external reviews or other mechanisms. And this element is really about finding out about your culture and what the gaps are in that before you start to generate an improvement plan. And so section 2 is about implementing improvements, and it's centred around 6 themes, including leadership, person-centred pathways, teamwork and communication, continuous learning, audit and benchmarking, and crucially, as lots of the speakers already have said, establishing capability and capacity for quality improvement. So each of those 6 subheadings have got a range of activities that are suggested that you undertake either in focus groups or in the wider perinatal team. And there are a range of solutions that have also suggested either through work that's already being undertaken by our perinatal professions or ideas that have been inputted by wider members of the perinatal team throughout the UK who've also submitted their improvement stories as well. And I think it's a real rich source of improvement information that is accessible to everyone who reads and accesses this toolkit. There are a lot of fantastic ideas from around the country. So but hopefully this is going to be out in the next month. There's going to be some very limited consultation over the next 4 to 6 weeks, and it should be out with you on the Bapm website, and we'll be distributing it more widely as well. And just really to summarise that culture and context are really indivisible elements of the environment in which we work on a day-to-day basis, and are key factors which can really enhance or limit our ability to work as one united and effective perinatal team. So thank you very much, and I'll hand over now to Manju Chandramani, who's going to speak to us about optimising place of birth for preterm infants. Thank you.
Hi, thank you, Julie Claire. I'm just going to get my slides loaded. Can you all see this? Well, I don't think
That's
you can
great,
all tell
Manju.
me. Perfect,
No,
thank
no,
you so
that's
much.
great. Thank you so much, Manju.
That was a silly question to ask everybody. Okay, so I'm giving this talk to talk a bit about place of birth within the areas that you've already heard about regarding antenatal optimization, and I'm doing it on behalf of the Pan London in utero transfer implementation team to give you an example of what we've done in London in terms of place of birth. And I currently am a consultant obstetrician at Guy's and St Thomas's Hospital. Okay, so we already have established, and you're all very much in understanding that place of extreme preterm birth matters, and this is just an example of the slide just shows various studies that have shown that there's a real improvement in perinatal mortality, if a real improvement in reduction of mortality if babies are born in a level 3 facility, and a lot of the data concludes that perinatal services should really be working together to optimize and facilitate delivery of the very small babies in tertiary hospitals. We've also heard about the Bapm optimization toolkit. You know about the MAT-NEO-SIP optimization bundles, and really what we're trying to encourage overall, and an example of this is through Preterm, is perinatal teams and system change. So in London, for example, and this is a figure from a few years ago, if 95% of babies under 27 weeks were born in a London NICU every year, it is likely that we would have 30 more babies who would survive. This is from the Bapm toolkit on antenatal optimization, and one of the key features of that was place of birth, and this slide shows you the improvement you would get if babies were born in the right place. And the antenatal optimization toolkit recommended that we ensure efficient and effective referral and transfer processes, and we establish various things as networks. Much of this is alluded to already by Julie Claire. You all know what an in utero transfer is, and what we need to do is focus on getting women or pregnant people to the right place. This is the situation in London. So we have 8 NICUs in London. They're all located very geographically close to each other. And what the problem has been over time is that everyone thinks that when a cot isn't found for a baby that's very preterm, someone else will find a cot because there's so many of level 3 units around. So geographically, it's not the same issue that other places in the country might have. So we set about doing implementation exercise for the Pan London in utero transfer guidelines that were released back in 2018. And I was part of the group that originally tried to enhance the implementation of these guidelines and to have improvement to show that we could achieve the national targets of over 85% of babies being born in the right place, because London was a big outlier in terms of being able to live up to that and perform. So we've done quality improvement activity, which has been embedded within this, and we had really good results with our pilot of over 6 months, where we were achieving the target. And then gradually, as time progressed, and COVID influenced that, but it wasn't the only thing that influenced it. We had a gradual decline to what previously the percentage of in utero transfers that we were achieving as a whole pre-implementation of the guideline. So then we went through this improvement activity to look at exactly what had happened, and we undertook this in November and December of 2021. We collectively mapped the pathway of the baby and the mother through the system with the key stakeholders, and we looked at relevant themes. And the themes really that to highlight were the inconsistencies in awareness and familiarity about the pathway, and this is 3 years after we thought that the guideline was released for everyone in London to be using. So it was really inconsistent what the communication roles and responsibilities of clinicians within were. There was a lot of variation in the practical handling of the request and adherence to the process outlined in the 2018 guideline. There wasn't a culture of ownership. There was a lack of escalation pathway for the EBS to follow in the case of repeated declines of acceptance of IUT, and there really was limited data to facilitate reviews and scrutiny. So the key updates in what has now been the next edition of this guidance is really involving the senior multidisciplinary team, ensuring that all the requests go through the emergency bed service, so we can coordinate everything for the region. There's a collective responsibility towards requests in the system, a pathway for escalation, which is really clear. The guidelines hopefully will be consistent and will replace any local existing guidelines. And there's a facilitation for data capture and analysis. So this was implemented across London on the 1st of August 2022. It built on the original vision, as I've highlighted, and it also involved the lived experience of the parents. We then had an effort to update these guidelines to include quality improvement and the outreach activity that we would need to do to try and improve on the experience of the frontline clinicians. And these are just to highlight some of the key areas where the MDT input insisted that a consultant and senior midwife were involved in the decision and the authorization to, if there was any thought of declining IUT, it really had to be at senior level. All the IUT requests needed to be happening through the emergency bed service. There was a clear pathway of escalation, which I'm about to show you, and it was all of our responsibility. So this is the pathway we've developed in London, and this is when everything is okay and smooth. This is what should happen, and it's very clear. And then if things the decision to accept a transfer is not ideal, then there are different escalation pathways, and this is level 2 escalation pathway when we're starting to feel pressure, operational pressure within the maternity system. And this is what happens when the red pathway is brought into state, and you're involving the obstetric consultant. You're involving the chief operating officer of the trust, and there's different escalation points to involve people that really need to know that we're not able to accept IUT in a perinatal centre. And this is other things that we've gone on to develop to just highlight how we're approaching this when things are operationally normal, when there's signs of pressure, and when there's major pressure in London. And this is kindly borrowed from Nina, and this is also going hand in hand with the IUT pathway. Is how are we going to escalate around London as to what our state of play in any given perinatal unit is, and the key focuses here would be on ward bed. There are 9 things: ward bed capacity, delivery suite bed capacity, triage breaches, the ability to really give one-to-one care in established labour, what your activity rate is, the dependency score of all of intrapartum care, what the supernumerary status of the delivery suite coordinator says, what delays you have in elective work and induction, what's in neonatal capacity, and what are the staff shortages due to unexpectedly high levels of sickness and absence. And this is how we're proposing to deal with after the event. And this we're hoping will happen through the LMNSs, and looking at cases in terms of what was expected, what actually did happen, why was there a difference, how can we better understand that, and what do we want to learn from this, and how can we adapt to future cases. And that's it in a nutshell, our experience and our direction of travel from here. Thank you.
Thanks so much, Manju. I think the issue of place of birth is a great challenge for many of us around the country, and I know in the Southwest today we were talking about your London pathway, and I know that other regions like the Thames Valley, Wessex and Oxford have had some real successes as well. I do think it's about sharing that approach. So to pull things together before we move on to questions, really today is about optimising care for women around the time of preterm birth to try to improve their outcomes. And I think we could, I think the key message is to really focus on this as a whole pathway. Andy's talked about some of the real challenges with trying to predict preterm birth accurately, allowing us to really target those steroids. It's so difficult, and I think we as neonatologists, Andy's right, we need to share in that cautious approach. We need to accept that there are times when holding fire is totally the right thing to do. We've talked about the multidisciplinary approach really needed to optimal cord management and express breast milk and early breast milk. And I really think that the common themes here are about the fact that this is everyone's responsibility. Leadership for improvement in this area is everyone's responsibility across the perinatal team to deliver this pathway successfully. So I'm going to hand over to Louise to chair the question and answer session. So please do put your hands up or type questions into the chat as we have another 20 minutes to focus on the question and answers.
Lovely, thank you ever so much, Sarah. So hello, good evening, everybody. My name's Louise Page. I'm a consultant obstetrician, and I'm currently the president of the British Interpartum Care Society, just for one more week until I hand the reins over to Susie Crowe. So if I could invite all of the speakers just to pop their cameras on. I'd just like to say thank you to all of you for your contributions this evening. I think that it's been really inspiring to hear about the work that's already underway in these areas. I think we've had well over 100 people join us, and so it's that kind of thing. If we can all go away and make one change on that pathway, one small step that will lead to other steps, just think about the impact that really could have on the health of babies born preterm. So as we come to the questions, I've got a few that I've jotted down as we've been going along that have come up, and if you wouldn't mind putting your questions either in the Q&A, or I'll look in the chat as well, or raise your virtual hand and we can come to people as well. So there was one question which I think Sarah, you put some thoughts in. I just was going to just give it to Tracy about optimal cord management when a mother has a general anaesthetic for a caesarean birth, and any tips on that situation.
Yeah, so we manage it just the same at caesarean section under general as we would do under spinal, because ultimately, because our neonatal team are standing at the theatre table with us, so we don't have that I've got to give the baby to the neonates and the neonates aren't standing there going, I've got to take the baby from the obstetrician. We're actually working as a collaboration team and giving the baby another minute or 2 minutes of a general anaesthetic when there is someone there to support the airway, and it is not going to make a significant difference, whereas waiting a minute or 2 minutes to clamp the cord is going to make a massive difference to that baby's morbidity and mortality. So we would do it just the same whether the lady's under general or under spinal.
Lovely, thank you. So there's a question that's come in. I'm going to direct to Manju initially. It's talking about the pressures within the system at the moment, and that certainly in my unit we have a special care unit, and so we have quite a lot of pressure sometimes to be able to try and facilitate in utero transfers out, and when our unit may be short-staffed, or the unit that we're trying to transfer to is short-staffed. it's just really that challenge at the moment that every shift it seems that we're down on midwifery numbers especially, and it was just about how do we how in London, I suppose, Manju, is the pathway trying to help support that when there are challenges, maybe both within the trust that's trying to arrange for a baby to be transferred or for a mother to be transferred, and those units that have the tertiary units that are on the receiving end.
Thank you, Louise. It's such a tricky question. I think we need to start thinking a bit more broadly, and we probably don't have all the data which we're hoping to capture through this exercise of looking at the events after the fact. Others talk about whether we work as a patch and try to work as an LMNS with that real-time shortage of staff, and do people sign up to work across patches because they work for an LMNS as a group of units? I don't know what the solution is going to be, but I don't think that there's real representation of the problem yet. We say it every day, we feel it every day. Every shift is really, really hard, but I don't think we've captured it in a way that the people who make those decisions regarding staffing really understand that yet. So I don't know what the solution is, Sandra. I really don't. But I think that we are not going to get better unless we start thinking of alternative ways to do it. Do midwives need to be the ones doing certain things, or can we look at other ways of using our workforce? Do we need a different type of workforce? Do we need nurses to provide a bit of a function, or another type of person, because there's not enough nurses either, but a different type of function around the cesarean section deliveries when they're elective list? Could another professional help with that side of things? Do we upskill our healthcare supporters, our midwifery support workers, etc., a little bit more? I think we have to think of other ways.
Lovely, thank you, Tracy. Did you want to come in on that?
Yeah, so in our area, sorry, my husband's just come home and has decided to start washing up. In our area, we have an agreement in the Southwest. We do actually have a meeting about inter-uterine transfers next month and how we can fix the system. But we did have an agreement that we would, from a staffing point of view, we would try very hard not to turn away an inter-uterine transfer, because ultimately, unless you've closed, and we very rarely close units in the Southwest. I don't know what it's like in London, but if you're open to a woman walking in labour, any woman walking in labour, then you should be open to accepting a threatened preterm labour from another unit to ensure that that baby is born in the right unit, because we know that having your baby in the right unit is fundamentally important and reduces morbidity and mortality. I mean, I work in a level 2 unit, so we obviously have to transfer out, and we only have 2 level 3 units, well 3, but nearly 2 level 3 units in the Southwest, so we don't have a lot of choice. But sometimes it's a case of having to move people around. We've certainly got much better in our LMNS to move inductions around, and we are moving inductions to other localities if we're very short staffed and women are delayed. And sometimes we have had a situation where we've transferred a woman to Plymouth and taken a woman from Plymouth who is a level 2 woman, so we can enable us, so we take their patient and they take ours. But I think we need to work as an LMNS, as a region, to be looking at this, and I don't think we should turn women away. And I know staffing is awful, maternity. I work on labour ward regularly, so we're always having the same questions and concerns.
Lovely. And I suppose just to about when we're thinking about that, and one of the key things with all of this when women are being transferred within the system is that handover of care, and the importance of that kind of conversations between the units, both written and verbal, so that all of that necessary information is travelling with that woman to a different unit. And I guess the not wanting to underestimate how stressful that is for a family to be transferred potentially some distance away from their home base. couple of questions have come in about magnesium. So maybe Sarah, if you wouldn't mind, just the questions I think both around the upper gestation for magnesium.
Yeah, Julie Claire's just put the nice guidance in the box, and I think the national targets very much emphasise all below 30 weeks, definitely, but to consider it up to 34 weeks, up to 33 plus 6, and I definitely know that in my own unit, I know one of my obstetric colleagues is on this today, would support up to 32 weeks for most of them. So yes, all below 30, but consider up to 33 plus 6. I'm well aware that you asked the neonatologist an obstetric question, but we're all part of the same perinatal team.
That's it. And I would say, so in my unit, we've gone for 33 plus 6, just so that it's the same as steroids, so that people are kind of not getting confused between, or when do I need to think about magnesium and which gestation do I need to think about steroids? So for that kind of clarity of message, for right or wrong. Andy, a couple of questions for you. One is about sepsis. So if you're concerned about maternal sepsis and steroids, and I can see it's just come back into the chat again. So could you just expand on
I think if
your thoughts about that?
I mean, if you have overt sepsis, then I think there's evidence that it's going to increase harm. And I think the important thing is to get people delivered rather than give steroids. The most recent WHO guidance, I sat on the tocolytic and steroid guideline group, is about to come out, and it elucidates the evidence very nicely. So you might want to look at those as they come out. I think obviously chorioamnionitis is incredibly common, and it can be covert, and therefore that is not a contraindication, you know. But I think if you've got, you know, a maternal septic situation, you just want to get the baby delivered, and you shouldn't delay for steroids. And I think steroids are known to increase morbidity. So when guidelines are directed to the international community, it's particularly important to avoid them. I think maybe not so much in our practice, but I would kind of direct you to the WHO guidance that's coming out.
Lovely, thank you. And another question, it was just I got sent a separate message offline about it, but I know that you'll be able to expand on it for us. It was about the importance of recognising women at increased chance of preterm birth, and about that association that we're now becoming much more aware of with previous caesarean birth at full dilatation. I just wondered whether you could just mention a couple of words about that, Andy.
Yeah, sure. I mean, on a practical note, what we know is that cervical trauma is caused by emergency caesareans. It's not rocket science. The presenting part, the cervix gets pulled up over the presenting part, and we have no idea where we're cutting. It all looks the same to us. So we cut the cervix, and we also now know that that increases the risk of delivering early. It's not a high risk, it's quite a modest risk. However, the type of preterm birth that it causes is early, it's recurrent, and it can't be treated. So in terms of its attributable risk to the problem, it's a big issue. So about 1,000 babies die each year now in the UK because of this problem, and we just don't recognise it. And we're struggling with how to treat it. These women with recurrent losses seem to benefit from abdominal stitches, and that's what we're looking into at the moment. I think the key thing is for us, when you have a woman with recurrent losses preceded by a caesarean, you have to know that the treatments are different, and the prognosis is poorer, and we have to teach our obstetricians to not de-skill in their operative vaginal delivery techniques, and not to always assume caesarean is the best option with our escalating caesarean section rate, which, you know, has gone up threefold in my career without as many benefits as you might think.
Yeah, thank you. Really important points there. I think that understanding that the causes of preterm birth are different, and that some of that is iatrogenic, and completely that we need to, as obstetricians, maintain and enhance our assisted vaginal birth skills, because that is sometimes absolutely the best course of action for both mother and baby. Another question, just sort of, I think, wanting just a bit more clarity about the sepsis. So if I think that what you're saying, Andy, is if a woman is unwell, then we should be cautious about using steroids. But if a mother's well, but there is some concern about some underlying choreo, that we could consider steroids in that situation. But it would be that if a mother was clinically unwell, that we should exercise caution. But in both situations, we need to be moving towards birth.
Yep.
Okay, perfect. Okay, question about optimal cord clamping. So term babies, we try not to clamp the cord for as long as possible, 4 to 5 minutes. Is there a reason why this can't be the same for preterm babies? It seems that people can't wait for the 60 seconds to finish to cut the cord.
No, you can wait as long as your baby is, you know, a cesarean section. I don't think I've waited 5 minutes just because particularly I want to crack on and carry on with the cesarean section. But certainly 3 minutes is certainly reasonable, and you know, often cords have stopped pulsating by about 3 or 4 minutes. At vaginal delivery, again, you can wait for 5 minutes of a preterm baby. You've got your neonatologist there. You've got the baby's nice and warm, and they may have the ability to give some respiratory support if needs be. It's a team game here, so we're all working together, and you should be communicating with your neonatal colleagues. So as I say, because our neonatal colleagues scrub at cesarean section, we talk to each other during that optimal cord management. We talk about the time and we decide when we would like to clamp the cord as a team. So yes, if you can wait 5 minutes at vaginal delivery, perfect, wait 5 minutes. It's not going to cause the baby any harm. Do you agree, Sarah, Julie?
Totally. I think we need to see the intact cord as it's not a proxy, it's the baby's life support machine. So there's a real urgency sometimes to sever that baby from its life support machine, but it's been doing the baby pretty well for the last, I don't know, 5, 6, 7 months, and we should aim to try and do at least a minute, if not longer. And just a word, I know Tracy, you've been using breaths, you know, ventilatory support and respiratory support. 90% of babies in the delayed cord clamping studies started breathing spontaneously in that first minute. So it is not necessary. Some people choose to do that because they feel it facilitates delayed cord clamping and makes everyone feel a little bit more comfortable, but lots of units don't use that and they just stand beside the obstetrician or midwife, and that works just as well as long as the baby's airway is supported and in the neutral position and the baby is stimulated to breathe. So the evidence that will come to help guide us one way or another with that, but just a suggestion that we don't all need to be doing that. It's whatever works best for you and the perinatal team.
And I would echo that. I mean, it's not, our neonatal colleagues are not necessarily scrubbed to give respiratory support, but actually for the more junior obstetricians, if they deliver a baby onto a mum's onto a warm area and the neonatologist is stood there scrubbed, the responsibility of the baby then becomes the neonatologist and not the obstetricians to make sure that the airway is open and that the baby has that opportunity to transition. So I think for me, our neonates are not necessarily scrubbed so they can give PEEP or respiratory support. They're scrubbed so the responsibility of the baby and managing the airway and making that team discussion of when you clamp the cord is you as a team. And I just worry that for our unit, if they weren't scrubbed now, we might go back to the, oh my goodness, do I need to now clamp the cord so I can give the baby to the neonatal doctor? So that's just the culture that we that what we've decided to do in our unit, and it works really well. I'm not suggesting that everyone needs to do that.
Lovely. A couple of questions have come in about concerns around jaundice in whether optimal cord clamping increases the chance of jaundice. So I don't know who would like to take that one. Sarah?
I'll default that to Sarah.
I can take that one. So in the trials which have looked at the bilirubin rate in babies who have immediate cord clamping or deferred cord clamping or optimal cord management, the actual change in the bilirubin level is really small. And really what we'd be asking is, does it make babies much more likely to need an exchange transfusion, which is a procedure with significant associated mortality and morbidity? And the answer is no, it does not. And so whilst there might be a tiny, not clinically relevant difference in the bilirubin rate in babies, it in no way causes impact that would outweigh the benefit for mortality and morbidity for the preterm babies, but also all the benefits that term babies experience from waiting. So I don't think the jaundice argument to me is should stop us from going away from the practice of immediate cord clamping, for which there was very little, if any, evidence in the first place.
Lovely, thank you very much. So I am going to draw us to a close, as we are now coming up on to 7:30. Thank you once again to all of the speakers for your contributions. Thank you to everyone for attending and for your questions, and I'm sure there would have been plenty of time to talk about this for another half an hour or more. You will get an email inviting you to give us some feedback. That would be really useful, so we can work out what works well and what you'd like us to do more of in the future. There won't be certificates as such, but in that email it does make a suggestion of how you can record your attendance for the purposes of appraisal, revalidation, CPD, etc. And for those of you that are coming to the Bics conference next week, we look forward very much to seeing you face to face, and we also look forward to welcoming Sarah and Tracy back to do a workshop explaining and delving more deeply into some of this work around optimising for preterm birth. Thank you all very much for your attendance, and we look forward to seeing you next time.
Thanks, Louise.